My name is Raymund Dantes, and I'm here to present the CDC Hospital Toolkit for Adult Sepsis Surveillance. I have no financial conflicts of interest or disclosures. Additionally, the findings and conclusions of this presentation are my own and do not necessarily represent the official position of the CDC. In this presentation, I will cover three main topics. First, the creation of the CDC Adult Sepsis Surveillance definition. Second, how the CDC Adult Sepsis event has been presented in the literature. And third, I will introduce the CDC Hospital Toolkit for Adult Sepsis Surveillance. So let's start with some background to understand how and why the CDC created a sepsis surveillance definition. In the CDC and the field of public health in general, we specialize in surveillance for infectious diseases and other conditions. We recognize that surveillance for sepsis has unique challenges. While there is overall agreement that sepsis is a life-threatening organ dysfunction secondary to dysregulated host response to infection, there is no gold standard definition and no definitive diagnostic test. Sepsis also covers a heterogeneous population with no single unifying objective criteria. For example, when we do surveillance for central line-associated bloodstream infections, we can narrow down the population quickly by finding patients with positive blood cultures in central lines. But this is not as straightforward with sepsis. Finally, the knowledge base is evolving with the recent publication of the Sepsis 3 definitions and new diagnostic tests in development. At the CDC, we established two goals for improving our collective knowledge of sepsis epidemiology. First, what is the U.S. national burden of sepsis and its associated mortality? Second, what are the recent trends in sepsis incidence and mortality? The primary source of sepsis counts has previously been administrative data, which is problematic for several reasons which we will discuss. I've shown here a chart from an internal analysis that our group did with CMS data, showing an increased frequency of hospitalizations with sepsis from 2008 to 2013, which at first looks very concerning. A number of studies have well documented this trend of increasing sepsis incidence and decreasing mortality at the same time when using administrative codes. This particular study is among hospitals in UPenn's network, and decreasing mortality is shown in box A, and increasing incidence is shown in box A, and decreasing mortality trends are shown in box B. Now, there are a couple of potential explanations for this phenomenon. If we trusted the accuracy of administrative data for sepsis, we could conclude that there were more patients developing sepsis, but we were also becoming more effective at treating sepsis at the same time. The alternative hypothesis is that perhaps the coding data is not as accurate as we'd hoped, and sepsis mortality is dropping because we are including and coding for more patients who are less sick. Well, why would we be coding more for sepsis now? Well, simply coding for sepsis actually pays more. I've included an example from the American Academy of Professional Coders, where a typical list of codes for influenza pneumonia hospitalization are shown on the left. That would result in a reimbursement of $5,694. When you take those same codes and add a code for sepsis, suddenly a hospitalization is worth $10,622 to the hospital, a difference of almost $5,000. In this case, the sepsis code nearly doubles the hospital's reimbursement. So we've established some concerns about using codes to administrative codes for measuring sepsis incidence. Another problem with the existing sepsis data was that it was really challenging to say how many people are dying due to sepsis, because the answer ranged widely depending on the data source you were looking at. This is a figure from an MMWR publication in 2016 showing sepsis mortality by the data source. Looking at death certificates gave you the lowest estimates, while some studies using various administrative coding definitions gave mortality estimates more than double that of the death certificates. So we've seen some of the issues with how sepsis is counted in administrative and death certificate data, but how is it being counted in various quality improvement initiatives? New York State's ROI's regulations, the methods for counting sepsis vary by hospital. They have the option to prospectively track patients that trigger a sepsis screen or to perform retrospective audits of cases flagged by administrative data. In CMS SEP 1, cases are identified by the explicit sepsis administrative codes, and the chart is reviewed to confirm cases. Both of these methods are improvements over simply using administrative codes, but both are still vulnerable to hospital-specific variation in coding or implementation. At the CDC, we thought we would take a different approach. We have an existing research network called the CDC Prevention Epicenters Consortium, which consists of academic investigators from many well-known institutions that are listed here. And they conduct innovative research in infection control and prevention. Over the years, it has been responsible for some of the landmark studies establishing the use and utility of chlorhexidine bathing for preventing healthcare-associated infections in ICU patients, among many other studies pertaining to the field of critical care. Dr. Chanu Rhee of the Brigham and Women's Hospital had already performed some foundational research in this field, and thus he was commissioned to lead a project with the following goals. First, develop a sepsis surveillance definition. Second, describe the national sepsis burden. And third, describe national sepsis trends. The first step was to develop a sepsis surveillance definition. The challenge here was how could we identify cases of sepsis using only objective data fields routinely captured in electronic health records. On the left, we have the sepsis 3 criteria, which are based upon the presence of infection and organ dysfunction, and for clinical care, that is described as the presence of at least 2 SOFA points. On the right is how we ended up conceptualizing the CDC Adult Sepsis event. In the field of surveillance, accuracy and consistency are most important, and we did not intend this definition to be used for real-time sepsis detection. We just want to know that when the dust settles, did this patient have sepsis or not? Thus, we define the presence of presumed infection as whether the patient had a blood culture obtained and at least 4 days of new antimicrobials administered. We then reviewed the SOFA criteria for organ dysfunction and modified them to create organ dysfunction criteria that could be captured consistently across a wide variety of electronic health record systems. This table compares the Sepsis 3 and the CDC modified organ dysfunction criteria. I won't go into all the details at this time because this is available in several places which we'll describe later, but basically each organ dysfunction criteria that we used in the CDC Adult Sepsis event is a simplified version of what is found in the Sepsis 3 SOFA criteria. I will point out at the bottom here in the neurologic category, the SOFA criteria are defined by varying Glasgow Coma Scale scores. However, this information is not routinely captured in many electronic health records and therefore was not included in the CDC Adult Sepsis event. Additionally, because of the wide use of lactate in identifying patients with sepsis, we included the presence of an elevated lactate in our CDC Adult Sepsis event definition. To test the performance of the CDC definition, we compared it to the Sepsis 3 criteria along with the implicit and explicit sepsis codes. We reviewed over 500 charts and found, as you can see here, the CDC definition offered better sensitivity than either coding definition when compared to with Sepsis 3 as the gold standard. The CDC definition was also highly specific and had a good positive predictive value. The performance, of course, was not a perfect match to the Sepsis 3 criteria because they were defined differently. And upon reviewing cases that were missed by the CDC definition and picked up by the Sepsis 3 criteria, these cases were often patients that were less sick, including patients with moderate hypoxia who were not on mechanical ventilation, for example. Next, I will discuss how the CDC Adult Sepsis event has been covered in the literature. So with the CDC surveillance definition that we had previously discussed, Dr. Chanu Rhee applied this definition showed in the blue box on the left to a network of 409 hospitals, approximately 10% of all U.S. hospitals, from the 7 data sources listed here. Using this sample and extrapolating to all U.S. hospitals, we estimated a national incidence of 1.7 million adult sepsis hospitalizations in 2014, and 270,000 deaths or discharges to hospice among patients with sepsis. This is how it looks when you compare our incidence to the two different coding definitions. First, I want to point out that we showed two different variations of the CDC definition, one in the darker blue with lactate and in the blue triangles without the lactate. The reason was that the use of the lactate test significantly increased during the time frame of this test, so it biases the trend to use and to include lactate when comparing years. So for this chart, I want you to focus on the light blue triangles, which are, again, the CDC definition without lactate criteria. And notice that the trend was flat from 2009 to 2014, in contrast to both the implicit and explicit sepsis codes that were increasing during this time. When looking at in-hospital mortality or discharge to hospice, again, the blue triangles showing the CDC definition minus the lactate criteria were flat, while both coding-based sepsis definitions show a decreased mortality during this time frame. Of course, since 2014, there have been a number of newer national efforts to improve sepsis early recognition and management, and we look forward to repeating this analysis in the future to see if these numbers are improving on a wide scale. Dr. Chanari also led a review article regarding the CDC Adult Sepsis Surveillance Strategy that has been published in BMJ Quality and Safety. It's a great introduction to the toolkit, and I'll highlight some of the main points here. The CDC Adult Sepsis Event definition has several strengths. It can be extracted 100% electronically from many electronic health record systems, so no chart review is necessary. This includes Cerner, Epic, the Veterans Affairs system, and many unique data warehouse systems. It uses objective data points, and no documentation of the word sepsis in the free text is needed. And when compared to administrative codes, the CDC Adult Sepsis Event is more stable over time and not vulnerable to coding practices. It also offers better granularity of sepsis onset date to help distinguish between community onset and hospital onset events. It is also possible to integrate sepsis surveillance efforts with antimicrobial stewardship efforts. Recall that the CDC Adult Sepsis Event relies on at least 4 antimicrobial days to identify presumed infection. Thus, the definition provides a mechanism for monitoring antibiotic use, and the presence of this definition can be used to encourage antimicrobial timeouts prior to the 4-day cutoff. Now, there are some limitations to the CDC Adult Sepsis Event. As we mentioned, it is not appropriate for real-time clinical decision-making. It relies on clinical judgments to define sepsis, so it is potentially susceptible to variations in practice. These clinical judgments include drawing blood cultures, prescribing antibiotics, and prescribing vasopressors. However, this is a limitation of all sepsis definitions. It can also identify patients with organ dysfunction unrelated to infection who otherwise received at least 4 days of antibiotics. And it may miss some patients who qualify for sepsis 3, since organ dysfunction criteria are not identical. We found that in chart review that the CDC definition does miss cases of milder organ dysfunction, such as hypoxia without mechanical ventilation, hypotension without vasopressors, and changes in mental status. Can the CDC Adult Sepsis Event be used to compare across hospitals is a question that we have heard a lot. Unfortunately, at this point, there is currently no validated risk adjustment strategy to compare across hospitals while adjusting for patient acuity and comorbidities. But we do think that the CDC Adult Sepsis Event can be used to compare incidence and outcomes across similar hospitals, acknowledging for this lack of risk adjustment. There are some implementation challenges I want to review. Automating the CDC Adult Sepsis Event requires significant upfront resources, including informatics expertise and programming resources, in addition to access to warehouse data from electronic records, and validation troubleshooting is likely necessary as well. Manual data abstraction forms are available in the toolkit if you do not want to use electronic data capture, but this is very resource intensive. In our experience, it took about 20 minutes to review each patient chart with who had blood cultures drawn and antimicrobials administered, and applying this to about 15% of all hospitalizations would be very time consuming. Thus, if you were to pursue a manual data abstraction, it may be more realistic to abstract just a sample of the interested cases, depending on your QI needs. Lastly, I'd like to introduce the CDC Hospital Toolkit for Adult Sepsis Surveillance. Based on the methodology I've described, we created a toolkit to help interested hospitals and health systems use the CDC Adult Sepsis Event definition to track sepsis for their own purposes. It's available now on the CDC website at the following links. We specify upfront that the toolkit is for certain surveillance purposes, but not all. It's intended for surveillance of sepsis incidents and outcomes among adult patients, but is not recommended for pediatrics because we did not use a pediatric definition. It is not intended to guide clinical diagnostic or therapeutic decision making. And as I mentioned, adjustment for patient risk factors and acute illness is currently not available. Therefore, it cannot provide risk adjustment comparison between hospitals. Some examples of some potential uses. It can be used to track sepsis mortality in a hospital during the implementation of a sepsis management bundle. It could also be used to track hospital onset sepsis in an ICU over time. It could also be used to track sepsis incidents in a healthcare system during implementation of an early infection identification program among elderly patients in nursing homes or home health systems. We actually offer two options for tracking sepsis events. The first is the adult sepsis event, as previously described and validated, that relies on the presence of a presumed blood culture and at least 4 days of new antimicrobials, and the organ dysfunction that we've highlighted previously. The second option is the bacteremic shock event, which is a simplified definition that tracks a narrower population with a higher expected mortality. This is logistically simpler to identify because it relies on microbiology and medication administrative data, and is simply defined as the presence of bacteremia or fungemia and administration of a new vasopressor. This slide shows again the organ dysfunction criteria that were used to help define an adult sepsis event. These are both in the toolkit and the previously mentioned JAMA paper. Next, I want to talk a little bit about implementation of the toolkit. We think it would generally be wise to perform a pre-assessment of sepsis diagnostic and treatment practices across the hospital prior to using the toolkit, as this will help you interpret your results and make recommendations for improvement. For example, if in your administrative and programmatic practices, it may be useful to review CMS Step 1 compliance efforts, the presence of emergency department, hospital ward, or intensive care unit sepsis teams, or the presence of a code sepsis team at your facility. You may also want to review electronic health records, sepsis prediction alerts or protocols that are already in use, and any trends in sepsis ICD coding. Clinical practices can also be reviewed, including emergency department sepsis identification and triage practices, similar practices in hospital wards or intensive care units, the presence and compliance with sepsis diagnostic and management protocols in your facility, any concurrent trials or quality improvement initiatives already underway, and any referral and transfer of patients with sepsis to other hospitals. For electronic case finding, the full data specs are available in the published toolkit, but for the adult sepsis event, you will need access to the following data categories: microbiology data, medication and administrative records, laboratory data, ICD codes to help identify end-stage renal disease or mechanical ventilation, CPT codes can also be used to identify mechanical ventilation. Patient outcomes, including death during hospitalization. And an optional category, if your electronic health record has alternative ways of recording patients on mechanical ventilation, that can be used instead of the coding mechanisms I mentioned above. For the bacteremic shock event, you'll only need access to microbiology data and medication administration records. Now, depending on your quality improvement needs, you may want to collect other optional data categories, including patient demographics, comorbidities, patient location within the hospital, additional microbiologic data, including pathogen identification, records of surgeries, procedures, and indwelling devices, additional patient outcomes like discharge to home, to a nursing home or rehab, and cost and billing data. If you are interested in the toolkit but don't have the ability to leverage your electronic health record system to automatically count sepsis cases, we do provide manual data collection forms in the toolkit as well. We also suggest outcome measures for tracking your progress. In this case, for community onset sepsis, instructions for calculating mortality and sepsis rates. For hospital onset sepsis, similar outcome measures. Finally, for data analysis and quality assessment, we provide formulas for calculating events and mortality rates. So we'll wrap up here in conclusion. The CDC Adult Sepsis event defines sepsis using clinical data available in a variety of electronic health records and has the following strengths. Full electronic determination, so no chart review is required. It's a closer match to Sepsis 3 than administrative codes. It's not subject to coding variations, and it's more stable over time. It can also be used to encourage antimicrobial stewardship. The CDC Hospital Toolkit for Adult Sepsis Surveillance is available at cdc.gov/sepsis and can help individual hospitals or health systems track sepsis incidents and outcomes to aid in various quality improvement initiatives. We would like your input and feedback. Please feel free to email me, Ray Dantes, at the email address listed here, vic5@cdc.gov. I'd like to especially thank Dr. Chun-Ari for leading these efforts and the immense amount of work he's put into this project, among many others listed here. Finally, I would also like to recommend our sepsis educational materials that are freely available on the CDC website. We have materials tailored to healthcare providers in a number of healthcare settings, as well as patients and families. We plan to update them periodically and hope these materials can help you in your efforts to educate others and improve sepsis awareness. Thank you.